introduction. And at the outset, I would like to thank Dr. Sanjay Kumar and GastroCare team for the kind invitation. And the topic of our panel discussion is, can I have the slides, please? So the topic is obesity management, medical management, surgery, endoscopy, how to choose. And the panelists with me are Dr. C.C. Chaubal, senior most gastroenterologist of Bhopal, Dr. Sushil Jindal, very senior endocrinologist from Bhopal, Dr. Salim Nayak, very senior surgeon from Amrita Institute, Delhi. No problem. So we will come to surgeons later. We will start with the topic, and we will be discussing the topic under the following outline. We will start with the definition of obesity, the prevalence of obesity in India, the medical complication associated with obesity, the pre-treatment assessment we need to do while treating a patient with obesity, the therapy goals, the options that we have, medical, endoscopic, surgical management, and guidelines how to use each one of these options effectively, and then summarize. So may I ask Dr. Sushil, how do we define and what is the prevalence of obesity in India?
Thank you, Saransh. I think when we define obesity, we usually go by BMI, though it's not the exact method to define obesity, because basically obesity means excess of fat in the body. But to delineate a fat in the body, you need to go for many sophisticated tests like MRI and DEXA scan, etc. So we are having a simplified method of classifying and defining obesity. So a normal person should fall in the range of 18.5 to 23 when we talk of Indian definition of BMI. And if the BMI is in between 23 and 25, we'll call the person as overweighted. And then comes the class 1 obesity, where anybody is having 25 to 30 BMI, it will be classified as class 1. And if he is between 30 and 35, will be classed as class 2 obesity. And after 35, we'll say that person is having class 3 obesity, or more or less we can say he or she is morbidly obese. Now these are the definitions for the Indian subcontinent, Southeast Asian population. But WHO and the Western definitions are slightly different. So their cutoff limits are approximately 5 more. So we can have like 25 and above, between 25 and 30, it will be it will be overweighted. 30 to 35 will be class 1. 35 to 40 will be class 2. And class 3, that is morbid obesity, will be called when patient is having above 40. Now regarding the prevalence of obesity in India, you have several studies done in several parts of the country, and it is found that it varies from something like 12% to 35%. It all depends upon the type of the population you've chosen. Now, most of the studies are being done in the urban population, and so the incidence or the prevalence is quite high. So you can roughly say that if you are choosing a urban population, higher income group, it will be around 30 to 35%. If you are choosing middle income group in say even in urban or in the rural areas, it will be around around 15 to say 30%, and then in the lower income group, it's definitely less. It's around 11 to 15%. So prevalence varies, and you can see in the chart that maximum incidence or maximum prevalence of obesity is seen in the US population. There are other populations even in the US, the trend is that the downtrodden population is more obese than the well-to-do population. In our country, it's just the reverse. So maybe some nutritional factors play a part in there.
So very important points given by sir. The two take-home points are, we as Indians are more predisposed to central obesity. Therefore, we get complication at earlier stage. So our obesity cutoffs are less. Second, this was once a disease that was rare in India, but now it is becoming increasingly more common in India. Recent study in Delhi showed every third person is obese there. And it is also increasing in rural areas nowadays. So it is an important perspective. The cutoffs are less and the numbers are increasing. So how do we deal with that? So what are the complications associated with obesity, if I may ask sir again? Medical complications associated with obesity.
Okay, I think obesity carries a lot of problems with it, and the first and the foremost is that it is psychosocially very, very disturbing for the patient. You just imagine a girl of 30 years not getting married because her BMI is 40. Psychological condition is very bad. So not only cosmetic problem, but also a psychosocial problem. There is, I know many of my patients, they have stopped going out just because, and there are some girls who have stopped going to college because people tease them with their obesity. So it's a big problem. This psychosocial problem remains a very big thing in the obese population. The second important thing is the metabolic problems. And you know that the obesity produces insulin resistance. And insulin resistance is mother of so many things. Diabetes, it is atherosclerosis, hypertension, dyslipidemia. So it is all the things are very directly correlated with insulin resistance. And with insulin resistance, with atherosclerosis, you have problems like, if you take central nervous system, very high incidence of stroke. You can also have high incidence of dementia. You can also have benign raised intracranial tension is also more in the obese population. Then coming to gastrointestinal tract, we all are discussing NAFLD and associated problems of cirrhosis and even hepatoma. And then we also know there is higher incidence of gallbladder disease, higher incidence of pancreatitis. So these gastrointestinal problems are also very, very common. Coming to the cardiovascular system, I already said that atherosclerotic coronary artery disease is very high. But not only that, cardiomyopathies and other things can also happen. Then coming to skeletal system, musculoskeletal system, osteoarthritis knee is very, very common. We daily come across patients complaining of pain in knees, and many of them end up with the replacement of the knees also. Osteoarthritis knee is very common. Then coming to the respiratory system, morbidly obese people, they have less vital capacity, and they can also go into the sort of hypercapnic respiratory failure because of the low vital capacity. So almost every system gets involved because of the complication of obesity, and definitely obesity, many studies say that it reduces the lifespan by almost 7 to 10 years.
So it is a prevalent disease. We are more predisposed to it, and it also leads to a myriad of complication apart from being bad itself. So we have a bad disease at hand. So how do we treat it? So what are the pre-treatment assessment that we do for an obese patient? May I ask Dr. Chaub?
So before actually moving on to an actual assessment, let me tell you, obesity as a problem has to be dealt by a good multidisciplinary team, which will involve a physician, a bariatric surgeon, sometimes an endocrinologist, the psychologist, the dietitian, psychiatrist, and some others also. So it's a kind of a team which evaluates and assesses the patients and subsequently treats. As far as assessment is concerned, in this evaluation of this problem is concerned, there's something called 5 A's, as has been mentioned here. It must be remembered, it is our experience also, and probably the experience of a large number of you people also, that obesity by and large is not considered as a major medical problem by a lay public, a large number of them. So first and the foremost thing actually is to ask the patient regarding the motivation that whether you really want to get your weight loss or you don't want to have a weight loss. Many patients, we have, in fact, so many times that we tell these patients many times, they simply say, हाँ साहब करा लेंगे ये करके, and they will never turn up. If he is ready, then advise what is to be done. Assess. You have to assess various aspects that we are going to discuss. Once the person is fully motivated, you evaluated, then assist him in getting a proper kind of a treatment. And subsequently, if he requires certain other procedures like this thing, you have to arrange for those particular procedures, like you want to go for an ESG or for surgery and all these things. So actually the entire evaluation and assessment remains on these particular 5 A's. Let me start off now. Evaluation, if you examine this particular patient, 3 things that are very important is the weight, waist-hip ratio. These are 2 very major things which are there that we have to see. Dr. Jindal has already given the pointers what is the normal weight and how it is to be done. Waist-hip ratio is also important. In our Indian patients, for example, the maximum recommended is about 34.5 inches, I would say. Coming to around 35 inches, I would say really difficult to achieve, but 90 centimeters is the maximum that is mentioned for the men. For females, it is about 85 centimeters, that is the waist circumference. So that has to be seen. Number 2, you have to look for comorbidity in this patient, whether he has along with that diabetes, dyslipidemia, hypertension, all these things, so that has to be addressed. Third thing is eating behavior. A large number of these patients have got certain eating disorders that you have to see very carefully. And remember this, it is definitely a major problem, and many patients do not come out unless they are specifically asked about this. Some serious eating disorders like binge eating, nighttime eating, bulimia and all these things have to be addressed by proper psychologists and behavioral therapists, where you have to take help of these. So you have to identify them. Fourth thing is, there are a number of secondary causes of obesity that you have to address. I will not go into certain congenital or very, I would say, certain genetic syndromes like Alzheimer's disease, Prader-Willi syndrome, and so many Froelich syndrome. They have certain other clinical manifestations also, and there are certain rarer varieties of this thing. But one of the very important things that must be considered is, for the secondary obesity, is a large number of commonly used drugs which are responsible for actually the gain in weight. You have antidepressants, you have corticosteroids, you have antipsychotics, you have anti-diabetics, so a range of medicines. You really calculate, look at them, almost 20 or 30 medicines which are very frequently used in clinical practice are associated with the weight gain. So if that is there, that also needs to be addressed properly. So this is how a full evaluation is to be done. Proper dietary evaluation, the medical evaluation already mentioned, the psychological. So all these things are involved, and they are compressed in this so-called 5 A's in this. Thank you.
So what are our therapy goals, sir?
Therapy goals are, all therapies that we are considering in managing this, ideally should have at least more than 10% of the body weight, which should be sustained for at least 1 year. Then there are several goals, for example, for pharmacological treatment also, several kinds of drugs which we'll be discussing shortly. It is said that any drug that you use for weight loss should be able to reduce at least 5% of the weight by 12 weeks. If it is not, then better stop the medicine.
So when we are talking about obesity, we are talking about a chronic disease with multifocal causes and a relapsing disease. So we need to keep long-term goals in mind. We need to have a therapy goal of at least 10% total body weight loss. Why 10%? Because it has been shown that when you lose 10% of your body weight, your risk for secondary problems like diabetes, hypertension reduces. That is why 10% cutoff was taken. And why durable? Because you want the treatment to at least continue its effect for 1 year when he is starting a treatment. So what are the diet and exercise goals for such patient? Dr. Jindal, if you can please elaborate.
I think any management of obesity will first start with diet and exercise only. you must remember that many patients will come to you and say that डॉक्टर साहब हम तो कुछ भी नहीं खाते फिर भी मोटे होते जा रहे हैं. So it's ultimately the calories will go in through your diet only. So you should remember that, and it's also known that many of these patients, they are eating subconsciously or unconsciously. There are very good experiments done. The patients were asked to recall their diet, and there were some hidden cameras put in their houses, and then it was shown to them that whatever they are telling, they are markedly undermining or understating the amount of calories they have eaten. And they were shown that how many times they opened the fridge and took something and ate, and that was not told by them. So they said, हमको मालूम ही नहीं, हमको याद ही नहीं कि हमने खाया था. So this is how they unconsciously also keep eating, and this adds to their caloric intake. And secondly, with obesity, another thing which comes simultaneously is they become more and more sedentary. For me, if I want a glass of water, I'll go and fetch water from the kitchen, but they will ask somebody, "Jara pani la ke dena mujhko." So they avoid caloric expenditure is automatically reduced as the patient gains weight. So it's very important that we should know that how the patient is eating, what the patient is eating. So don't go for very drastic reduction in the caloric. Patient will not adhere. Very low calorie diets, they are not recommended. Something like less than a crash diets of 800 calories or less per day, they should be avoided. Patient is not going to stick to that diet for a very long time. So what is recommended is that you should go for something like 1200 to 1500 calorie diet, which patient can stick to it, can adhere to it, and also manage to it. And for that, we need to tell the patient that all the calorie-dense foods should be avoided. And they usually mean that the fats and oils and the fried items and the high sugary items should be avoided. Better to take more of the protein, and unfortunately, in our country, protein deficient diet is highly prevalent in all corners of the country. So it's very important. Then there are some more good things is that increasing the fiber content in the diet will give them satiety. I always ask the patient with obesity and diabetes that take a full plate of salads and fruits, then take a glass of water and then start eating. So that it automatically reduces the amount of calories it's going to consume in that particular meal. So this is very important. Then comes the exercise. Now various organizations tell that for a healthy person to avoid cardiovascular risk, and even for the diabetes, we say that 30 minutes moderate intensity workup should be done at least 5 days out of the 7 days. But here, when we want to avoid weight gain or want to reduce weight gain, we have to go a step further. We usually ask them to walk for at least 45 minutes. And they should also remember that diet is more important than exercise. Now, if I go to gym and walk on treadmill at a moderate intensity for say 1 hour, the total calories displayed there are 240 calories or 220 calories. I come back and take a paratha, and in my breakfast, that is 350 calories are going in. So it's very important to remember that diet restriction of the calories is very important part. Then the exercise is definitely helpful. In type of exercise, if the patient is already suffering from osteoarthritis, then asking him to go for a long walk may be actually detrimental. So for them, probably the best exercise is to have an exercise bicycle at their home, because by that bicycle, their weight will be transferred on the seat and there will not be any weight bearing on the knees, which will further damage the knees. So then it's very common now for us to have a step counter in our mobiles. We usually encourage patients to go for at least 10,000 steps a day. Normally, there is a very important paper very recently published which says that 7,000, if anybody who walks 7,000 steps a day, he is likely to live some 10 years longer than a person who is not walking. And after 7,000 to 10,000, there is no further gain. So at least 7,000 should be, for us, should be the step counts a day. But for obese person, it should be more than 10,000 so that he can burn some calories, and he can also see some diet restriction, and he'll be able to lose some weight. And definitely then there are criteria to start medical therapy, and there are also criteria to go for the bariatric surgery.
Thank you for enlightening us, sir. And the main point here is very low calorie diet should not be started on their own. Sometimes people start like 600 calories, 800 calories. They're not sustainable. They lead to usually protein loss and muscle loss. So it's 1200 to 1500 kilocalories, and you need to have exercise, because this exercise will build up your muscle, which will increase your basal metabolic rate. Once muscle are there, increase in basal metabolic rate also burns up some calories. So it is important to exercise those muscles. The composition of diet, as sir said, increasing salads, fibers, filling up your stomach before you enter the major meal is also a very important factor. When we look for therapy options for obesity, we have lifestyle, we have medication, we have endoscopic procedures and surgical procedures. As their efficacy increase, so does the risk associated with them. So how do we choose between different therapy options for obesity? So the main characteristics for treatment for obesity is it should be safe, it should be effective, it should be durable, it should be acceptable to people at large, and it should have favorable impacts on comorbidities. Do we have such a Raman Dava? I don't know. Let's see. So, what are the medical therapy options, sir?
See, medical or the pharmacotherapy for obesity, the record is very, very dismal. Now, it all started with various hormones. Actually, very first trial was done on thyroxine. And we still come across at least once or twice a year that some lady is purposely taking higher dose of thyroxine to reduce weight. डॉक्टर साहब आप वेट ये गोली आप कम कर देते हैं मेरा वजन बढ़ने लगता है तो मेरे को ज़्यादा गोली पे रहना अच्छा लगता है. So this is very common that thyroxine is a drug which was very anciently used for reducing weight, and then even HCG was tried. But you can see when we were student there was a drug known as Pondrex. Very commonly used drug in those days. That was fenfluramine, and it was also available in fenfluramine combination also, but that drug was banned. Then we had rimonabant and then sibutramine, they were also banned, and very recently lorcaserin was also banned. So one after other every drug got discontinued because of some or other reason. FDA was very strict on these drugs. But here I can show you that what are the drugs available and what are the good drugs. Now we know the lowermost line shows the bariatric surgery, very drastic change in the weight, and it is also maintained to some extent. Then just this second line is for tirzepatide. Now this is GLP-1 plus GIP agonist, and this drug again is coming up in a big way, and it will be almost wonderful drug. It in the highest dose it produces almost 17 to 18% weight loss, and which is very well maintained till the drug is taken. Then comes this semaglutide, which is available in the US in higher doses of 2.5 milligram, and this is known by the name of Wegovy. And this again is a drug which is coming up. This drug we have been using for treatment of diabetes, and this tirzepatide also will be very good drug to reduce HbA1c. And then the third one is a combination of topiramate with phentermine. Now this is probably the third most important. Just see on the other side, if you see the very first dot in the go back please.
Sorry, sir.
In the first dot, which is for Orlistat. Now take Orlistat for 1 year, and majority of studies say that it will reduce weight by 3 to 5%. That means a 100 kg person will lose 3 kg, and what he is spending 48,000 rupees in a year. So it's almost, and then that weight loss is also not maintained. And you can see in the lowermost, the dot in the blue, lowermost, that is again tirzepatide, and then uppermost is semaglutide. So you can see that on the lower axis, it's approximately 12 to 18% weight loss can be achieved. And this, the orange dot is for again phentermine plus topiramate. Topiramate is a drug used very commonly by the psychiatrist for bipolar disorder, and also as an anti-epileptic drug by neurologist in pretty high doses also. So we can use it, and it's also a very good drug for prevention of migraine also. So I think phentermine, being a sympathomimetic drug, can increase the heart rate, can also produce some rise in systolic blood pressure, so it may not be required. But yes, topiramate is a good drug to be tried in obesity. It is available in India, but it is not been cleared for as anti-obesity, but this can be used. Other drugs, you can see they have very less than 10% reduction in weight.
So when coming to medical therapies, we have found that there are few promising drugs in the pipeline. Oral semaglutide has been launched in India. Tirzepatide has an NEGM trial recently published. And the main advantages of pharmacotherapy are its widespread acceptability. It's just a pill. Everybody loves a pill. But the limitations are, as you see, that only a few drugs have good efficacy. A lot of drugs don't have efficacy. The durability of is also an issue, because once you stop taking the drugs, the weight gets more. And the side effect profile of some drugs might not be acceptable to a large number of patients. When we talk about endoscopic management options, we have intragastric balloons. I would like Dr. Chaubal to enlighten us about the intragastric balloon options that we have.
See, now the concept behind use of intragastric balloons is you introduce some space occupying thing in the stomach which gives you a sense of satiety or a very early satiety, so that you are not able to complete a meal and you suddenly feel full. That was the concept which long back Gare and Edward balloon was introduced, and subsequently the so-called BIB or the biological intragastric balloon was introduced. We have had several modifications of this, and about 2 or 3 kinds of balloons have been approved by FDA USA to be used. There are several other balloons also. If I just go for that, you have so-called Orbera balloon, you have an adjustable Spatz balloon, you have an aileron balloon. Other than that, you have Obalon balloon, reshaped duo balloon, Ellis balloon, and probably 1 or 2 more balloons which are there. The concept of all these balloons is, most of these balloons, when they are put in the stomach, the endoscope is used. By endoscopic monitoring they are put in. There are a couple of balloons which are swallowed just like a capsule without the help of an endoscope. Most of these balloons actually are filled by saline, which is usually mixed with some methylene blue. They are usually made of silicone or some such material which doesn't disintegrate easily with the effect of gastric acid. They stay in the stomach for a long time. Usually they are allowed to stay for about 6 months. If you want to have a repeat use, you can use it for further 6 months, but not beyond that. The idea of saline-filled balloons is, when they are mixed with methylene blue, any leak, if it happens accidentally, the methylene blue gets excreted into the urine and the urine becomes blue in color. So you know that the balloon is leaking and you can immediately take it out. Most of the balloons which are put in are subsequently retrieved by deflating them and subsequently taking them out of the endoscope. There is one, however, capsule on which the trials are still going on. The so-called GLOW trial is there, and that is called a Gelesis 100 capsule. This is a kind of a hydrogel capsule which contains about 1,000 biodegradable particles in the hydrogel particles. The property of these particles is, when they come out in the stomach, they absorb water and they swell up. They occupy around 25% of the volume of the stomach, remain in the stomach and gradually get expelled in the intestine. And all these granules, as they go down in the colon, they are subsequently degraded by the bacteria over there. So the beauty of this particular capsule, if it really becomes successful, would be that it doesn't require any endoscope for introduction, nor does it require any endoscope for retrieval. So that's an absolutely non-invasive thing. However, the problem with the balloons is, whenever we use these therapies, we talk in 2 terms. You talk of percentage loss of excess body weight. So whatever body weight is there in excess of your overall stature, that is called excess body weight. Or you can talk in terms of total body weight loss. That means whatever weight you have, this thing. So if you look at the total body weight loss, majority of the balloons actually result in not more than 15% of the weight loss. Like in drugs, 5 to 8% weight loss is there, not more than that. But balloons also tend to maximum about 18% weight loss is there. So where would you use them? We usually recommend using these balloons in some of the very obese individuals as a bridge therapy. You give these particular balloons, they will start losing weight. For about 6 months they are allowed to stay. They lose sufficient amount of weight, you can take the balloon and subsequently send the patient for a definitive endoscopic, either endoscopic therapy or for surgery. So usually we use them as a stopgap measure, and some people have been using like off-label indication is obese female is there, wants to get married, you put in balloon for some time, she loses weight, gets married, and subsequently the balloon can be removed. So that is the kind of thing which was there. So usually it is used as a bridge therapy, I would say.
So when we talk about intragastric balloons, the advantage is it's acceptable, it's a minimally invasive option, it's an endoscopic option. Nowadays a without endoscopic option is also there. It has a better efficacy than drugs, around 5 to 10% total body weight loss is available. The limitation is durability. 1 year you have to remove the balloons. What about that after that? And balloons have some short-term side effects like nausea, vomiting, feeling of fullness, which have to be explained to the patients. When we talk about endoscopic management, now we have some other options also available, which are stomach restrictive procedures. We can discuss about that with Dr. Chaubal.
In fact, the endoscopic options which are available have, I would say they came a little after surgery, and looking at the concept of surgery, whether to have a restrictive procedure or so the first surgical procedure, I think Dr. Salim would say, like sleeve gastrectomy, where you tend to reduce the size of the stomach. So endoscopically, this can be achieved by using two techniques actually. Endoscopic sleeve gastroplasty is one. There are several procedures which are already there with the endoscopies which have gone to the graveyard of endoscopy. I would say they are all gone. What remains now in the forefront is the so-called endoscopic sleeve gastroplasty, where you reduce the size of body of the stomach by using certain pleating sutures, or you can use so-called pose. Pose is also a type of a gastroplasty where the sutures are actually placed more towards the anteroposterior distal part of the stomach. So that is there. These procedures definitely result in weight loss, which is significant. I think about 20-25% weight loss is definitely there in this with this particular procedure. These procedures are reversible. If you want, you can reverse them also. Otherwise, we can be allowed to continue for several years. And so much, we have about track record of about 10 years now with endoscopic sleeve gastroplasty. Not much adverse effects are seen, and it's quite effective in this situation. Many times these endoscopic procedures are also used as a bridge therapy to reduce the weight of super obese or morbid obese patient to a certain extent, and subsequently they can be sent for definitive surgical bypass, restrictive or malabsorptive procedure, or whatever you want to choose.
So regarding the volume restriction therapies, different companies have different platforms. They name it differently. What they are trying to do is they are trying to reduce the size of the stomach. Once your size of the stomach reduces, you feel early full, you have early satiation, and a longer satiety because of the delayed gastric emptying. So the advantages is that it is acceptable, it's a minimally invasive option, it has medium efficacy with 10 to 15% total body weight loss at 2 years. It has minimal side effects, very less incidence of nausea, vomiting as compared to balloons. It is quite safe. No major side effects have been seen recently in endoscopic restrictive therapies. But long-term results regarding durability are not yet available because of the new nature of these processes. We have 5 years data. Whereas when you talk about bariatric surgery, as we will in few slides, we will have 20 years, 30 years data regarding bariatric surgery. So what are the surgical management options, Dr. Salim, that we can have for obese patients? And may I ask Dr. Kanungo to even add something of his experience?
The surgical options, there are over 20 different bariatric procedures that have been described and tried by different surgeons in the world. But the most 3 common procedures which have worldwide acceptability and are approved and done all across the world. This is the gold standard is of course the Roux-en-Y gastric bypass. Then we have the sleeve gastrectomy and the mini gastric bypass. The mini gastric bypass initially started with a lot of controversies. It was a procedure, it was devised by a surgeon by the name of Dr. Rutledge. He was a US-based surgeon, and he was banned from practice there as the FDA did not approve of this procedure. And we found it to be quite a favorable procedure as far as the Indian population is concerned. Most of our patients are very happy with this procedure. This was taken up by Mohit And Rutledge was in fact called by him to demonstrate the procedure here, and it picked up quite a speed in this country. One of the most commonly done bypass procedures by surgeons who do gastric bypasses. And now it has also been approved by the FDA, and we are in talks with a lot of these stapler companies like Ethicon and Covidian, who now want surgeons from US to be imported to learn this procedure, as studies have shown that it's a much less morbid procedure. The morbidity is much less as compared to the RYGB. But if we talk of one surgical procedure that has stood the test of time, it's of course the Roux-en-Y gastric bypass.
So when we talk about surgical options, here we are basically changing the anatomy of the digestive tract to reduce the weight. There are two aspects to it. One is volume restriction of the stomach, and second is malabsorption. When you talk about restrictive options, sleeve gastrectomy is the option. You remove a part of the stomach and increase gastric emptying is there, reaching the food to the terminal ileum, which causes increasing satiety. When you have malabsorptive procedures, you have Roux-en-Y gastric bypass, where a part of the stomach is removed. However, there is a loop of the intestine attached to that part, so that the part of the intestine is also bypassed. This proximal intestine, which gets bypassed, has also a lot of metabolic effects. It has improvement in diabetes, which is independent of sometimes its weight loss effects, and also mini gastric bypass, which is technically a little different, but metabolically similar as Roux-en-Y gastric bypass. May I have opinion of the chairperson, Dr. Rajesh, also?
Yeah, both all three options are the standard procedures these days, and in case of bypass, diabetes resolution is the effect is immediate. I mean, before any weight loss, the diabetes resolution starts.
Yeah,
so
independent
that is due
of
to
the weight
hormonal
loss.
changes in the body. And the surgical treatment of obesity is, I think you can say, it is a long lasting, say about 5 years, or in some cases 8 years. The weight regain is there, but it is not very significant in the patients who are very sincere in taking their diets and exercise and everything.
So the advantages of surgery are that it has good efficacy, it has a durable results with mild side effects in experienced hands. The limitation is acceptability. Despite surgery being present for a long period of time, a lot of patients who are eligible for surgery rarely undergo surgery. So to incorporate all these aspects, AGA came up with power guidelines, which are practice guide on obesity and weight management. Here there are 4 aspects to treatment of obesity. There is assessment of patient, there is intensive weight loss intervention, there is weight stabilization and re-intensification when needed, and prevention of weight regain. So first there is a cornerstone therapy, which is done as a primary therapy after assessing the obesity, and then there is intensive weight loss phase, and then a second level therapy if there is weight regain or weight maintenance is required, with reassessment of obesity and leading to a circle why you can repeat this cycle. When we talk about cornerstone therapy, the first option for overweight is diet and lifestyle modification. Sometimes when they have comorbidities, we can also give them pharmacotherapy. When it is class 1 obesity, apart from lifestyle, diet modification and pharmacotherapy with comorbidities, you can offer them endoscopic therapies. When it is class 2 therapies, we start with pharmacotherapy, endoscopy therapy, and in surgery in patients with comorbidities. When it is class 3, we prefer surgical treatment, but all the above options are also included. You must also notice that in all the options, the lifestyle, diet, physical and behavioral therapy also continue. So it is not that you have undergone surgery, you forget about diet, lifestyle and behavioral. So it is a behavioral disease. People are born to eat that way. They don't do it by choice. You have to change that behavior. That is very important to understand that it is a disease. It's not a cosmetic procedure that we are doing. It's a disease. We are treating a disease. So when we talk about second level therapies, for weight regains, we can do either endoscopic therapy, pharmacotherapy, or revisional surgery if the primary treatment was a surgical procedure. So I would like to involve now all the panelists as well as the chairperson for any future prospects in bariatric management that they feel like. Dr. Shailendra Dubey sir, if you have any comments here.
I want to ask the important question that this is one of the genetic cause and secondly psychological cause. How the obesity is dependent on psychological effect and the obesity itself causes so many psychological problems. How many percent of the patient of obesity you come across who's having a psychological problem first, then they become obese?
Most of the patients who have obesity have a very, very poor body image. So, but if we talk about, clinical depression, and if a patient is having a clinical psychiatric disease or anything, that's one of the contraindications for obesity surgery, for him to undergo obesity surgery. Because many of these patients have ascribed all the troubles and problems in their life only to their weight, which is many times not true. And once the weight goes away and they feel that, the things did not everything settles with weight. There's a lot of other things in life besides the being overweight that is giving them those issues or those problems, those mental illnesses. So these are a select group of patients who should not straight away be subjected to intensive weight loss therapies. They can try for other medical therapies like putting up a balloon and, till they get acclimatized to that, they feel what are the things that are going to go away and what are the things that are not going to go away. And eventually when they earn their surgery, that is the time when they should undergo the knife. I really do not know whether this is what you meant by the question. This is what I felt you were trying to ask.
Dr. Chaval, I ask you about this intragastric ballooning. How long you can keep it and how many balloons you can put it in?
See, I have already mentioned that by and large, when you put it for the first time, the duration which is given is for 6 months. 6 months. If you have, then you can deflate it if required. If you think the weight is steadily losing, patient is losing, you can continue for another 6 months also. They can refill that, put the balloon back, refill it and continue for another 6 months. But not more than 1 year. That is very clear. Number two, how many balloons? Balloons means there are, most of the balloons, they have a capacity of 450 to 700 cc. But there are 3 balloons which are not filled with saline, but they are filled with air. Nitrogen containing air, nitrogenous air is there. That is the Oberon balloon. They swallow it, the air is put in, it swells up. After, say, about 2 or 3 weeks later, another balloon is added to that, and similarly at the interval of 2-3 hours, 3 balloons can be put. So 2 or 3 balloons like that can be put in the stomach for some time like that. So that is the Oberon balloon. But most of these balloons actually are available as a single balloon. There is only one thing which is there, which is also known as reshaped duo. These are 2 balloons which are attached with a catheter. So they are instilled and subsequently the water is filled in, then the same saline, the methylene blue contains this thing. The idea is if one of the balloon deflates, at least it will not migrate because of the other balloon which is there. That is the concept in this.
Did you ever came across regarding the obstruction?
No, obstruction, no sir. I have very limited experience. I have some experience with the SPATS balloon, actually, adjustable SPATS balloon. The balloons are not very popular in Bhopal. But one thing is definitely there, sir. Once you put in a balloon, it is not, it's a lot of discomfort is there. Intense nausea, vomiting, sometimes to the extent that you have to admit patient for initial 2-3 days for parental infant, all these things. And the acceptability is not very high. I have an experience with one patient who lost about 7 or 8 kg of weight, but subsequently came back after 1 month, Doctor Sahab, isko nikal dijiye karke. And finally he agreed to go for final surgery. He was scared of surgery because someone had 1 or 2 casualties had happened in Bhopal following surgery, so people are very scared. So he was one of them, but subsequently agreed for surgery, went somewhere else to get his, I think he underwent gastric bypass in that situation.
Did you ever use mixing of this biliopancreatic juice in jejunum? Any device?
Which one?
blue pancreatic juice, mixing
No,
of blue pancreatic juice, because that is the main cause for obesity. And
Since there are diversionary procedures which are there, since there are, what we have mentioned just about the intragastric balloon, but there are large number of other therapies which are not FDA approved. Like you have so-called Baronova or the transpyloric shuttle is there, you have so-called Satisware, Valent TX, and there are so many other devices also which are there. I have not mentioned them for short of nothing. And there are certain devices which prevent the absorption. Like you had an endo barrier which was there and it was in use for a very long time. But subsequently they found that there is an incidence, almost 3% incidence of hepatic abscesses. So that device was taken away. There are similarly various kinds of surgeries are there which are trying to actually produce a kind of a malabsorption. They are restrictive also at the same time and malabsorptive also at the same time. So there are devices which are still there. And I think Salim will tell us that there are many newer re-intervention procedures which are endoscopic and surgical also. Like some patients who start gaining weight again, then what are you going to do in that particular situation?
So obesity is a disease of brain and gut. So in future, I think there should be a good medication or any procedure to prevent it. So I conclude the session because short of the time and
one more
future,
slide, then we
yes.
conclude. So obesity is a chronic relapsing disease. No one therapy will fit all the patients. Individualized therapy is recommended based on BMI but also informed choices of the patient. And a multidisciplinary team and regular follow-up are key to success. Thank you.